injury.
So hello
And,
friends,
adaptation.
our today's topic is cellular injury and adaptation.
So we shall be discussing about
So
cellular
for a
injury
normal
and,
cell
adaptation.
homeostasis, the cell maintain a balanced internal environment. So when it is exposed to conditions like stress, the cell can undergo a process that is known as cellular adaptation to cope with the changes. However, if the stress it is too severe or prolonged, cell will experience mild, transient and reversible injuries. Meaning they suffer some damage, but they can recover if the stress is removed. So this type of injury does not cause significant harm and does not lead to long-lasting damage to the cells. Whereas the irreversible injury, it refers to the severe damage that cells cannot recover from, leading to cell death. So what are the main two mechanisms of the irreversible injury? One is the necrosis and other is apoptosis. So necrosis is a type of cell death that is caused by factors like trauma, infection, lack of blood supply. It involves the cell swelling, rupture and inflammation. So the content of cells it spill out and cause harm to the neighboring cells. Whereas the apoptosis, it is a programmed cell death. Remember, apoptosis, it is known as a programmed cell death. So it is a controlled process where the cell will shrink, their DNA will break, and they will get packed into apoptotic bodies. That are engulfed by nearby cells or phagocytes without triggering the inflammation. So how do the reversible cell injury occurs? There are two common cause of the cell injury are the number one is the ischemia, that is lack of the blood supply, and the second is the hypoxia, means the low oxygen. So if they are not severe and don't last too long, the cell can recover. So as we know that the cells, what they need oxygen to make energy. So what the ischemia and hypoxia they both will do is they will lead to reduced oxygen supply and leading to less energy. That means there will be less ATP. So oxygen, we know it is needed for the aerobic respiration and glycolytic ATP production. So without enough oxygen, but you will see there will be switch to anaerobic glycolysis. That means there will be build-up of lactic acid. So this lactic acid will cause decrease in pH. So there will be clumping of the nuclear material. So increased lactic acid would cause decreased pH and that would cause clumping of the nuclear chromatin. So lack of the ATP will affect the repair of the cell membrane. So the membrane pump that regulates sodium and calcium, it will fail. So what will happen? Sodium will accumulate. That will cause influx of the water. So there will be increase in influx of calcium, water and sodium, due to which water will enter the cells and there will be swelling. So there will be also influx of the calcium, so that will damage the mitochondria and the membrane. The continued hypoxia would cause swelling of organelles like endoplasmic reticulum, ribosomes, which are essential for the protein synthesis. So they become dispersed and again less functional. So in the reversible injury, removing the stress, if you remove the stress, the cell can return back to the normal state. So when ischemia or hypoxia it continues for too long, the cell cannot recover and it will suffer irreversible damage. So cell can't recover from mitochondria problems even when the oxygen is restored. So that would lead to issue with the energy production. So cell membrane, especially the outer ones, stop functioning properly. That is the major event in the irreversible cell injury. There will be too much calcium that enters the cell, especially after the oxygen is reintroduced. That will damage the mitochondria, causing structural changes. First of all, there will be enzyme that is phospholipase. So the enzyme phospholipase, it will break down membrane phospholipids that are important for cell structure. So that is caused by calcium influx and low ATP. The cell support structure called the cytoskeleton, it would also get damaged. This is due to activated protease. So there will be activation of protease that will disrupt the cytoskeleton proteins, or swelling leading to irreversible membrane damage. There will be endonuclease, ATPase, all enzymes would cause nuclear damage. So the nuclear damage would lead to nuclear condensation, that is pycnosis, fragmentation, that is karyorrhexis, dissolution, that is karyolysis. Along with that, the lysosomes will break open due to lack of oxygen and low pH. So enzymes like protease, lipase will digest the cell component, causing the cell death. So there will be leakage of the cell membrane. The damaged cells would release enzymes into the bloodstream. So these enzymes can be measured to indicate the cell death. That is useful in diagnosis condition like heart attack. So from ischemia to different cell states, we can see three states. One is the short ischemia. So if the lack of blood supply is brief, so reintroducing the oxygen through reperfusion helps the injured cell recover. So that can cause reversible injury. Other is the long-term ischemia with reperfusion. So when the ischemia it lasts longer, reintroducing the blood flow would worsen the already injured cells. So that is known as ischemia reperfusion injury. And if ischemia goes on for very long time, it will cause irreversible cell changes. So where the cell is damaged beyond recovery, even when the blood flow is restored, it does not help because of severe damage to the cell membrane and excess sodium and calcium intake. So this reperfusion injury involves the three main factors. Number one is the calcium overload. So when the blood flows increase, the cell will receive blood with higher calcium levels while having low energy, that is ATP. So this causes the further calcium to enter cells, damaging the cell membrane. Second, there will be reactive oxygen radicals. So restoring blood flow would generate reactive oxygen radicals like superoxide, hydrogen peroxide or hydroxyl radicals. So that will cause oxidative damage to the cell component. And the third is the inflammatory reaction. After reperfusion, inflammatory response can be triggered that would further damage the cells. Now, what are the things that you would see in the reversible and irreversible cell injury? First of all, for the mitochondria, for the reversible part, there will be mild swelling. There will be formation of amorphous density. There would be swelling. For the cell membrane, you would see there would be myelin figures. There will be cell swelling along with the blebs formation. For the nucleus part, the important is the nucleus part. The chromatin may show mild changes. It can recover. Karyolysis, pycnosis, they are generally not present. Clumped chromatin may be seen. So the cytoskeleton may show some damage, but it can recover. Ribosomes may detach, but they can be restored, whereas in the irreversible cell injury, the mitochondria would show severe swelling. That is irreversible. The cell membrane would show significant damage, that it would be irreversible. Myelin figures may be formed due to cell membrane breakdown. The nucleus, there would be irreversible damage. There would be pycnosis, karyolysis and karyodexis that would be discussing later on. There would be severe damage to the cytoskeleton. Ribosomes will detach and they cannot recover. Now let us discuss the generation of the reactive oxygen radicals. As we know that oxygen, it is vital for the cells, can also form dangerous molecules like reactive oxygen radicals or species. So these molecules would harm the cells. So how they are produced? As we know that the cells, they use oxygen to generate energy, that is the ATP, through a process. So this process creates water from the oxygen and the hydrogen. Sometimes instead of just making water, the oxygen forms a molecule with unpaired electrons, creating radicals. So these radicals include the superoxide, hydrogen peroxide and hydroxyl radical. So how these radicals are produced? First of all, the superoxide, it is formed from the oxygen directly through enzyme, that is xanthine oxidase or cytochrome P450. So the super oxide dismutase, it will further change into hydrogen peroxide. So the catalase and glutathione peroxidase enzyme inactivated. From that hydroxyl radical, it is formed from the hydroxyl radical. It is formed from the water radiolysis or by reacting hydrogen peroxide with the ferrous ion, that is also known as Fenton reaction. So other reactive oxygen radicals are generated too, like nitric oxide, hypochlorous acid. So these are generated through various different processes. Some environmental factors like tobacco, pollutants, they also contribute to free radical formation. Now, what is the effect of this reactive oxygen radical? Free radical, they are created in normal and disease situation. So if they are not managed, the free radicals would harm the cells by binding to the molecule. So this is oxidative stress, and hydroxyl radical is particularly harmful. So remember, the free radical, they can damage the cells in three ways. Number one is by lipid peroxidation. Attack on the membrane fatty acids leads to lipid peroxidation, damaging the membrane and organelles. Proteins can be damaged through oxidation, causing cell injury. There can be DNA damage or cytoskeleton damage. So these reactive oxygen species, they can interfere with the cell structures, impacting energy production and the ATP. So following morphology form of the reversible cell injury, what are the changes that would be seen? The first is the hydropic changes. Second is fatty changes. Third is hyaline changes. And fourth is mucoid changes. What is hydropic changes? That means the water accumulation in the cells. So it is also known as hydropic, is also known as, remember, cloudy swelling. So what are the causes? Causes from various harmful agents like toxin, chemical burns, etc. So caused by disrupt sodium and potassium balance at the cell membrane, leading to water inflow and cellular swelling. So gross appearance, the affected organs like kidney or liver will swell and appear opaque. On a microscope, what you will see, you would see swollen cells with compressed microvasculature, vacuoles, small clear vacuoles, cytoplasmic blebs, and pale nuclei. Other is the hyaline changes. Hyaline changes means the cells or tissues appear glass-like, glassy, and homogeneous under microscope. So it can be either intracellular or extracellular. Example is hyaline deposit in the proximal tubular epithelial cells. Other is the Zenker degeneration that occurs in the typhoid fever, where you would see hyaline degeneration. So remember, for your MCQ exam, Zenker degeneration in typhoid would show hyaline degeneration. Other is Mallory's hyaline in the hepatocytes in the alcoholic liver cells. Other is the Mallory hyaline. It is seen in alcoholic. Other is the Russell's body. These are the Russell's body. Excess immunoglobulin that could be seen in the rough endoplasmic reticulum of the plasma cells. Other could be extracellular hyaline that occurs in the leiomyoma of uterus, or diabetes mellitus. You would see hyaline arteriosclerosis. Third is the mucoid change. Mucoid means accumulation of mucin. So that is related to chronic inflammation or tumors. The cells would look like gelatinous or slimy. The cell would contain mucin-like vacuoles. The fourth, the last, is the fatty change. So fatty change means accumulation of fat droplets that is due to the excessive alcohol intake. The organs may appear pale, enlarged. The cell contains viable fat droplets. So these are the reversible cell changes. The irreversible cell changes, the nuclear changes, important for your entrance exam is this one is the normal nucleus. What is pycnosis? Pycnosis means that when the nucleus gets shrink, then when there is nuclear shrinkage and there is increased basophilia, this is the term is known as pycnosis. What is karyorrhexis? Means when there is fragmentation. You can see the pycnotic nucleus when it gets fragmented, break up down into different pieces. It is karyorrhexis. And karyolysis, you will see fading of the basophilia of the chromatin. So here the chromatin fades away. So these are the nuclear changes associated with the irreversible cell injury. Now, what are the pigmentation that could be seen in the reversible changes? You could see melanin-like pigments. The first is the melanin-like pigment. Seen in alkaptonuria and Ewing-Johnson syndrome. Alkaptonuria, it is a autosomal recessive disorder that is due to deficiency of oxidase enzyme. It occurs due to the accumulation of homogenetic acid that causes ochronosis, that is melanin-like pigment deposition. It affects joints, cartilage, capsule, ligaments, and tendon. Other is Ewing-Johnson syndrome. It is a hepatocyte containing melanin-like pigment in the cytoplasm. The other is the heme protein-derived pigment that includes hemosiderin, the iron stored in the tissue as ferritin, and hemosiderin. It is a golden yellow-brown granular pigment seen in mononuclear phagocytes of bone marrow, spleen, and liver cells. Acid, hematine, bilirubin, porphyrin, lipofuscin. It is also known as wear and tear pigment. So which is wear and tear pigment? It is lipofuscin. It is a yellowish brown intracellular lipid pigment. It is where it is seen in atrophied cells of old age. So it is seen in old age. It is also seen in myocardial fibers, hepatocytes, Leydig cells of testes, and neurons in senile dementia. Other are the exogenous pigment. The exogenous pigment, they are introduced into the body from the external sources like the inhalation, ingestion, or inoculation. They include the inhaled pigments like carbon, coal, dust, silica, iron, asbestos. Organic particles are inhaled. Alveolar macrophages pick up these pigment. Second are the ingested pigment. Ingested pigments like certain metals, when chronically ingested, can lead to pigmentation like argyria is due to silver.
that causes due to silver, the lead poisoning can cause blue lines on teeth, carotonemia, skin changes due to excessive carrot consumption. And the last is the injected pigments like tattooing, pigments like ink, cinnabar, carbon. They are introduced into the dermis during tattooing. The macrophages will take up these pigments, resulting in permanent pigmentation in the connective tissue. So these exogenous pigments, they can have various effects on the tissue and may lead to conditions like immunoconiosis, altered skin discoloration, and permanent tattooing. So the next topic is apoptosis versus necrosis. The apoptosis and the necrosis, these are the two different types of the cell death. So apoptosis, it is often defined as programmed and coordinated cell death. So that can occur in the various physiological and pathological signals. Whereas necrosis, it is an uncontrolled and accidental form of cell death that occurs due to the external factors like the physical injury, toxin, lack of oxygen, or the infection. So the necrosis, there will be degradation of the tissues by the hydrolytic enzyme. So the apoptosis, it involves a series of cellular events that leads to fragmentation of the cells into the apoptotic bodies that are engulfed and removed by neighboring cells without causing inflammatory reaction. So most important point is, in apoptosis there will be no inflammatory reaction. So in this apoptosis, the cell death, where the cells activate enzymes to break down their own nuclear DNA, fragments break off, giving a falling off appearance. The cell's outer membrane, it remains intact, but it is changed to attract the phagocytes that remove the dead cells and the fragments. So this happen quickly. So that is why there is no inflammation. Unless apoptosis, the necrosis, does not involve the breakdown of the cellular component. Instead, the inflammatory reaction is always present. In apoptosis, there is death of single cells, whereas necrosis, there is death of many adjacent cells. The necrotic cells, they swell initially. They ruptures and release their content, including the enzymes and other molecules that can damage the surrounding cells. Whereas the apoptosis, it is characterized by cell shrinkage, chromatin condensation, and cell membrane blebbing. So cytoplasmic blebs on the membrane disruption occurs. In apoptosis, there is formation of apoptotic bodies, chromatin condensation, etc. Whereas in necrosis, there is damaged organelles, nuclear disruption, it occurs. In necrosis, there is lysosomal breakdown with liberation of the hydrolytic enzymes. Whereas in apoptosis, you will see the organelles, lysosomes and other organelles will remain intact, and there will be activation of caspases pathway. So this is the feature of the necrosis and apoptosis. Remember, the cell size is
there is enlarged in necrosis, whereas in apoptosis there is shrinkage. The nucleus undergo changes like pycnosis, karyolysis, and in apoptosis there is fragmentation into nucleosome size fragments. The plasma membrane is disrupted, whereas in apoptosis it is intact. So remember all these features and differences between the necrosis and apoptosis. The pycnosis, karyolysis we have discussed earlier also. Now let us discuss main about the necrosis and its types. Necrosis and its type. There are the types of necrosis can be either coagulative necrosis, liquefactive necrosis, caseous necrosis, fat necrosis, or fibrinoid necrosis. Let us discuss them one by one. The first is the coagulative necrosis. The coagulative necrosis, it occurs, it is type of necrosis that results from the focal injury due to the sudden loss of blood, like ischemia. So which organs are most commonly affected? Heart, kidney, and spleen. So the area will appear pale, firm, and slightly swollen. Over the time, it will turn yellowish, softer, and shrunken. So on a microscope you would see a feature of that is tombstone appearance of the cells. Very important that tombstone, this the coagulative necrosis, it retains the cell outline resembling a tombstone, although the cytoplasmic and the nuclear details they are lost. So remember, for exam point of view, you have to just remember the coagulative necrosis, it is seen in infarcts of solid organ, except the brain. So it is seen in the infarcts of solid organs. So this one is the normal spleen and showing the coagulative necrosis with the spleen. So this type of necrosis will denature both the structural protein and enzyme. The other form is a liquefactive necrosis. So that is caused by ischemic injury due to the powerful enzymes breaking down the tissues. The example of it is brain, infarcts, and the abscess. So the affected area will turn soft with liquid center containing debris. So on microscope you will see cystic space that holds dead cell debris and macrophages. The liquefactive necrosis, it appears in the bacterial or the fungal infection. So the dead cells, they are entirely broken down, converting the tissues into the liquid. Other type is the gangrenous necrosis. It can be of three types: wet gangrene, dry gangrene, or the gas gangrene. So gangrenous necrosis describe a limb, often the lower limb, that has lost its blood supply, and it experiences coagulative necrosis affecting the multiple tissue layers. So when the bacterial infection occur on the top of this, the coagulative necrosis can change due to its liquefactive action of the bacteria, and it can attract the leukocytes and leading to what known as wet gangrene. So wet gangrene, it occurs in the naturally moist tissues and organ like
mouth, bowel, cervix, vulva, and diabetic foot. It can also develop as bed sore in bedridden patient due to pressure on the sides. So remember, the wet gangrene, it occurs due to blocked venous flow to the blood that causes thrombosis or embolism. So the affected area would appear soft, swollen, rotten, especially in case of gangrene of bowel due to conditions like hernias, etc. Other is the dry gangrene. Dry gangrene starts in the distal part of the limb. Remember, it starts in D for dry, D for distal part of limb. It occurs due to the reduced blood flow. Example is thromboangiitis obliterans, that is Berger disease, Raynaud's disease, etc. So dry gangrene, it slowly spread upward until it reaches an area with adequate blood supply, forming a line of separation between the necrotic and the viable part. The affected part would appear dry, shrunken, and dark black due to the hemoglobin relieved from the lifed RBC, reacting with hydrogen disulfide, forming a black pigment. So the wet gangrene is due to the venous obstruction, it is due to dry gangrene is due to arterial obstruction. Wet gangrene occurs in bowel, dry gangrene limbs. Wet gangrene, there is moist, swollen, dark morphology, whereas in dry gangrene it appears dry, shrunken, and black. There is no clear line of demarcation in wet gangrene. There is presence of line of demarcation. So remember all the differences between the wet gangrene and the dry gangrene. The another form is the gas gangrene. It is caused by gram-positive anaerobic bacteria, that is Clostridia, which are gram-positive anaerobic bacteria. So these bacteria will enter the tissue through open wound. So the Clostridium bacteria will produce toxin that would cause tissue necrosis, edema, and cause severe symptoms, like there will be formation of accumulation of gas bubbles within the tissues. So these tissues become dark, black, and emit a foul odor. The muscle fiber will undergo coagulative necrosis with liquefaction. The other necrosis is the caseous necrosis. It is a type of coagulative necrosis. It is seen in tuberculosis infection, and it is named for its cheese-like appearance. So, the caseous necrosis, the area will resemble a soft, granular, yellowish, dry cheese. So microscopically, this necrotic area will be structureless, eosinophilic, and contains the debris, granular debris, and the most important part is you will see the Langerhans giant cells surrounded by rim of lymphocytes.
So there will be granulomatous inflammatory reaction with epithelioid cells, Langerhans cells, and rim of lymphocytes. The other type is the fat necrosis. The fat necrosis, remember, for MCQ point of view, it is seen in pancreas and breast. It is seen in pancreas and breast. So in pancreas, injured or inflamed tissue release enzyme that is pancreatic lipase. So that will cause a necrosis. The fat necrosis break down the fat cells into glycerols and fatty acids, so giving cells a cloudy look. So fat necrosis, it is yellowish white firm with calcium soap making it chalky white. So under the microscope, these fat cells, necrosed cells, fat cells would appear cloudy appearance. The other is the fibrinoid necrosis. That is, there is presence of fibrin-like material. It is seen in conditions like autoimmune disease, hypertension-related arterioles, and peptic ulcers. Now let us come back to the apoptosis. Apoptosis, as we know, it is a form of cell death where the cell active enzymes break down their own nuclear DNA and protein. So this, there will be the cell outer membrane remain intact, but it is changed to attract the phagocytes that removes the dead cells. So this all process occur very quickly. So that is why there is no inflammation. So concise and accurate deposition, description of apoptosis. First of all, there is cell shrinkage, there is chromatin condensation, budding apoptotic bodies, they are formed. These apoptotic bodies, they are phagocytized and there is no associated inflammation. So what does the process of apoptosis involves? The process of apoptosis, it involves number one, 4 stages. The first is the death signal. So this stage involves various signal or triggers that initiate the apoptosis process. That can come from 2 pathways. One is the external pathway and other is the internal pathway. Second is the execution. So in this stage, a series of molecular events occur, including the activation of the most important is the activation of caspases. So what are caspases? These are enzymes responsible for the cell degradation and cleavage of the cellular components. So this stage, the cell will undergo structural changes like chromatin condensation. There will be alteration in the cell membrane and formation of apoptotic bodies. The third phase is engulfment. So apoptosis bodies, they are recognized and engulfed by the phagocytes, such as macrophages, without inducing inflammation. So this stage ensures the removal of the apoptotic cells and prevent the release of harmful cellular content. The last stage is degradation. So during this stage, the apoptotic bodies that has been dismantled and packed are further broken down, recycled by the phagocytes,
and ultimately contributing to the clearance of these apoptotic bodies without causing any inflammation. So these are the steps that are involved. Now let us discuss the mechanism of apoptosis. So number one, as we discussed earlier, that apoptosis, it happens when the enzyme, which enzymes? They are the caspases. So these caspases will cut protein. So what are these caspases? They are a group of proteases, enzymes that break down. These caspases will do what? They will break down protein. So with the unique ability to cleave target protein at specific amino acid sites. So this precise cleavage of protein by caspases, it is the central feature of apoptosis. So two types of, remember there are two types of proteins. One are the, remember, is the pro-apoptotic protein. And other is anti. One is pro and other is anti. The pro will promote the cell death. The pro will cause cell death. So the pro will cause cell death by triggering the release of cytochrome C. From the mitochondria. So that will activate the caspases, and they, which in turn would cause would cut the protein. So the example of pro-apoptotic proteins, remember, is backs and back. Backs and bad. So remember, the mnemonic backs and back, they are bad. So they promote cell death. The anti-apoptotic will prevent the cell death. So example is BCL2. So remember, BCL2 is, it is good. Backs and back, they are bad, and BCL2 is good. So these are the anti-apoptotic proteins. They prevent the cell death. So they help maintain the cell survival by inhibiting the caspase activation and maintaining the integrity of the mitochondria. So a balance between the pro-apoptotic and anti-apoptotic proteins will determine whether the cell will survive or not. So this is the mechanism of apoptosis. Now coming to the pathway. So there are basically the two main pathway. One is the extrinsic pathway and the other is the intrinsic pathway. The extrinsic pathway is also known as death receptor. Whereas the intrinsic pathway, it is also known as mitochondrial pathway. Right? So let us discuss the intrinsic, that is mitochondrial pathway first. So when the cell, it will lose growth signals, damaged DNA, it will
it will activate the protein like BH3. That will trigger backs and back. So these forms channel in mitochondria, allowing the proteins like cytochrome C to escape, activating the caspases, and that will cause on other hand, the anti-apoptotic proteins like BCL2 will block the backs and back. Now the radiations, toxins and hypoxia, these all can play a significant role in initiating the mitochondria pathway of apoptosis. So this, first of all, the mitochondria pathway of apoptosis, it is typically initiated when cell receives signals indicating loss of survival factors or conditions that threatens the cell health, like radiations, toxins, hypoxia, DNA damage, or accumulation of misfolded proteins. So in response to these signals, there will be sensors. The sensors, they are activated. So these sensors, these are the member of BCL2 protein, especially BH3 protein. So the BH3 protein trigger the activation of two pro-apoptotic protein back and back. So these channels allow the release of proteins that are within the mitochondria, most commonly the cytochrome C. As we know that cytochrome C, it is a crucial component of mitochondria respiratory chain, involving in generating the ATP, cellular energy. So when it is released in cytosol, it plays a central role in apoptosis. So when cytochrome C, it binds to other molecules, it forms a complex that will activate the caspase 9 activation. So that is the initiator, one of the initiator caspases. So the activation of caspase 9 will initiate a cascade of events, and again it will cause activation of caspase 3. So these caspases, they are responsible for carrying out the dismantling of cells during apoptosis, cleaving various cellular proteins. So a balance between the pro-apoptotic and anti-apoptotic proteins determine whether the cell will undergo apoptosis or not. If the pro-apoptotic signals dominate, the backs and back, they will active and leads to cytochrome C release and apoptosis. And if the anti-apoptotic signals will prevail. The other pathway is the death receptor, that is the extrinsic pathway. So remember, the cells have special receptors on their surfaces like FAS and TNF. So these receptors are like switches that controls the cell survival. So when these receptors, they are turned on by signals like the FAS ligand or TNF, they start working. So turning on these receptors causes them to call for help. So they invite the adapter proteins to join the party. So these adapter proteins are like crew that helps set up the special machines. So after out a crew of adapter proteins arrives, they get to work. So one of their main tasks is to activate a special enzyme, that is caspase 8. So think of caspase 8 as boss of this operation. So its job is crucial in starting the process of the apoptosis. So here is where the things get interesting. The caspase 8, our boss, does not just stop here. It can also activate other protein, that is BID. So you can think of BID as important messenger. So this activation of BID, it is connecting the two pathway, the death receptor pathway and the intrinsic pathway. So the connection makes the signal for apoptosis even stronger, like turning up the volume of sound. So BID's job is to travel to the mitochondria, that are the powerhouse of cells, trigger the release of certain proteases like the cytochrome C. So these proteins are usually stored within cytoplasm, but BID signals them to come out of them. So once the cytochrome C and other apogenetic factor, they are out in the cytoplasm, they sets a chain of reaction that will cause activation of downstream caspases. So these caspases are responsible for the cell death. So the BID, it acts as a messenger that strengthens the signal for apoptosis by connecting the death receptor pathway to the mitochondrial pathway. So this ultimately results in release of key protein, the activation of caspases and dismantling of the cell. Now last is the clearance of these apoptotic cells. So the apoptotic cells, it will send eat me signals that will attract the nearest phagocytes. So the phagocytosis process leaves no traces of dead cells, and therefore it causes a minimal inflammation. So this is how the apoptosis process occur. So the early cell death might involve apoptosis followed by necrosis as the condition worsen. So this was all about apoptosis and necrosis part.